Welcome to Dr. Madhu's MedEd International, where we bring you clear, clinical, and concise concepts. Let's get into today's lesson. Before we even think about choosing a drug, we must step back and ask a more fundamental question. What exactly is causing the patient's symptoms? In clinical practice, patients do not present with diagnoses, they present with symptoms. Symptoms like anxiety, low mood, agitation, or psychosis are nonspecific and can arise from multiple underlying causes. Prescribing at this stage, based only on symptoms, is one of the most common causes of irrational pharmacotherapy. The first step is to rule out medical conditions that can mimic psychiatric illness. Endocrine disorders, infections, metabolic disturbances, and neurological illnesses frequently present with psychiatric symptoms. Failure to identify a medical cause can lead to inappropriate psychotropic use and delayed definitive treatment. Next, we must actively assess for substance-induced symptoms. Alcohol, cannabis, stimulants, sedatives, and even excessive caffeine can cause mood changes, anxiety, psychosis, or sleep disturbances. Treating substance-induced conditions with psychotropics without addressing the substance use leads to poor outcomes. Many commonly prescribed medications can produce psychiatric side effects. Steroids can cause mood elevation or psychosis. Anticholinergics can cause delirium, and some antidepressants can worsen anxiety initially. Recognizing drug-induced symptoms prevents unnecessary addition of new medications. Only after excluding medical, substance-related, and drug-induced causes should we establish a formal psychiatric diagnosis. Using standardized criteria such as ICD-10 or DSM-5 ensures diagnostic accuracy, uniformity, and evidence-based treatment selection. Accurate diagnosis is the foundation on which rational prescribing is built. In examinations and real-world practice, remember this principle. Wrong diagnosis leads to wrong drug, and wrong drug leads to poor outcomes, especially in psychiatry. Once an accurate diagnosis is established, the next critical step is to decide whether medication is actually required. Severity assessment helps determine the intensity of treatment required. Mild psychiatric conditions may respond well to non-pharmacological interventions, whereas moderate to severe illness usually requires medication. Severity also influences drug choice, dose, and urgency of intervention. Functional impairment refers to how much the illness affects daily functioning, work, relationships, and self-care. Even when symptom severity appears mild, significant functional impairment may justify pharmacotherapy. Risk assessment is a priority in psychiatric prescribing. The presence of suicidal ideation, self-harm, aggression, or risk to others often necessitates prompt pharmacological intervention. After assessing severity, function, and risk, the clinician must decide whether drug treatment is indicated. Not every psychiatric diagnosis automatically requires medication, especially in mild or situational conditions. This step prevents unnecessary exposure to drug side effects. For patients with mild symptoms, preserved functioning, and low risk, non-pharmacological strategies may be sufficient. Psychoeducation, psychotherapy, and watchful waiting are evidence-based options. When pharmacotherapy is indicated, choose a first-line agent supported by clinical guidelines and evidence. Guidelines such as APA, NICE, and Maudsley help ensure that prescribing is rational, standardized, and defensible. Empirical or habit-based prescribing should be avoided. Before finalizing the prescription, always weigh the expected benefit against potential risks. Side effects, drug interactions, long-term consequences, and patient preference must be considered. Medication should be prescribed only when the anticipated benefit clearly outweighs the risk. In exams and clinical practice, remember, the indication for a drug is determined not just by diagnosis, but by severity, function, and risk. Once we've decided that medication is indicated, the next step is to choose the safest and most appropriate drug for this particular patient. Age significantly influences both pharmacokinetics and pharmacodynamics. Children and elderly patients are more sensitive to psychotropics and more prone to adverse effects. In older adults, drugs with anticholinergic effects, sedation, or orthostatic hypotension should be avoided whenever possible. Sex-related differences affect drug metabolism, body fat composition, and hormonal influences. Women may experience higher rates of certain adverse effects, such as weight gain or QT prolongation. Sex-specific considerations are especially important in long-term psychopharmacology. In pregnancy and lactation, prescribing requires a careful risk-benefit analysis. Avoid known teratogens, use monotherapy at the lowest effective dose, and prefer drugs with established safety data. Untreated psychiatric illness can also harm both mother and fetus, so decisions must be individualized. Medical illnesses significantly influence drug choice. Cardiac disease, renal impairment, hepatic dysfunction, epilepsy, and metabolic disorders can all contraindicate certain psychotropics. Ignoring comorbidities is a common cause of serious adverse drug reactions. Past response to medications is one of the strongest predictors of future response. Similarly, a positive family response to a particular drug may guide current choice. This principle helps reduce trial and error prescribing. Active or past substance use must always be assessed. Some psychotropics have abuse potential, while others may interact dangerously with substances like alcohol or opioids. Prescribing without considering substance use can worsen outcomes and complicate recovery. Cost, availability, and access to follow-up care influence adherence. A drug that is effective but unaffordable is clinically ineffective. Rational prescribing always considers the patient's real-world circumstances. Before prescribing, actively look for absolute and relative contraindications. Some drugs are unsafe in specific medical or physiological conditions. This step prevents avoidable harm. Psychotropic drugs frequently interact with other medications through pharmacokinetic or pharmacodynamic mechanisms. Interactions can increase toxicity or reduce efficacy. Always review the complete medication list before prescribing. Certain drugs can worsen underlying diseases. For example, anticholinergics may worsen glaucoma or dementia, and some antidepressants may lower seizure threshold. Recognizing drug-disease interactions is essential for safe prescribing. If a significant contraindication or interaction is identified, the drug should be avoided. An alternative with a safer profile must be selected. Safety always takes priority over familiarity or preference. When initiating treatment, begin with a low dose to minimize side effects and improve adherence. Titrate slowly, especially in vulnerable populations such as the elderly or medically ill. However, ensure that the dose eventually reaches the therapeutic range. After selecting the appropriate drug and dose, the next step is to ensure safe initiation and ongoing monitoring. Before starting treatment, obtain a baseline assessment. This includes vital signs and relevant laboratory investigations depending on the drug being prescribed. Baseline values help identify contraindications, guide dose selection, and provide reference points for future monitoring. Patients should be informed about the expected benefits of treatment. Explaining what improvement to expect and when helps build realistic expectations and strengthens the therapeutic alliance. Clear communication improves adherence. Discussing potential side effects in advance prevents anxiety and improves early reporting. Patients are more likely to continue treatment when they understand which side effects are common, transient, and manageable. Patients must be informed about the expected duration of treatment. Premature discontinuation is a common cause of relapse in psychiatric disorders. Clear discussion of duration reduces non-adherence. Emphasizing the importance of regular adherence is crucial in psychiatry. Irregular intake can lead to partial response, side effects, or withdrawal symptoms. Adherence is as important as drug choice itself. Prescribing does not end with writing the prescription. A scheduled follow-up visit allows assessment of response, tolerability, and adherence. During follow-up, assess symptom improvement and functional recovery. Clinical response guides decisions regarding dose optimization, continuation, or modification of treatment. Actively monitor for adverse effects, especially during the initial phase of treatment. Early identification allows timely intervention, dose adjustment, or switching of medication. Unrecognized side effects are a major cause of noncompliance. Some psychotropic drugs require regular laboratory monitoring. Comparing follow-up values with baseline helps detect toxicity or emerging medical complications. Once treatment is initiated, the next critical step is to wait, assess response, and make rational adjustments. Psychotropic medications require adequate time to show clinical effect. For antidepressants like SSRIs, this usually means 1 to 2 weeks for initial response, while antipsychotics may show improvement within days. A poor response means minimal or no improvement, despite adequate dose and duration. This signals the need for systematic reassessment rather than empirical polypharmacy. A partial response indicates some improvement, but persistent symptoms remain. This requires careful evaluation rather than immediate switching. Partial response often reflects inadequate dose, duration, or adherence. Dose optimization involves increasing the dose within the therapeutic range. This is often the simplest and most effective step when response is partial and side effects are tolerable. Switching the drug is considered when there is inadequate response or unacceptable side effects. Augmentation involves adding another agent to enhance response. After any change in treatment, reassessment is essential. A good response is characterized by significant symptom reduction and functional improvement. When this occurs, the correct approach is to continue the same medication without unnecessary changes. Treatment must be continued for the recommended duration to prevent relapse. Stopping medication early is one of the most common causes of recurrence in psychiatric disorders. After stabilization, decide between maintenance therapy and gradual tapering based on diagnosis, recurrence risk, and guidelines. Abrupt discontinuation should be avoided to prevent withdrawal and relapse. All decisions, responses, and changes must be clearly documented. Documentation ensures continuity of care and provides medico-legal protection. Just as starting a drug requires clinical judgment, stopping a drug also requires a structured and safe approach. Discontinuation is an active treatment decision, not an afterthought. Improper stopping of psychotropic medications can lead to withdrawal symptoms, relapse, or rebound worsening of illness. The first step is to assess whether the drug is known to cause withdrawal or discontinuation symptoms. If the drug is not associated with withdrawal, it can be stopped safely, often without tapering. Medications such as benzodiazepines, antidepressants, and some antipsychotics commonly require tapering. Slow dose reduction allows neurobiological adaptation and reduces the risk of withdrawal and relapse. The tapering schedule should be individualized based on duration of use, dose, and patient vulnerability. After discontinuation, patients must be monitored for return of symptoms or withdrawal effects. Early detection allows timely intervention, including reinstating treatment if necessary. Follow-up is essential during this phase. For exams and clinical practice, remember, abrupt discontinuation of psychotropic drugs is a common cause of relapse and withdrawal. Tapering is safer than stopping. Let's now tie everything together into a simple, repeatable framework for safe psychiatric prescribing. Begin with an accurate diagnosis using ICD-10 or DSM-5 criteria. Always rule out medical, substance-induced, and drug-induced causes before labeling a primary psychiatric disorder. Ask a critical question. Is pharmacotherapy indicated right now? Consider illness severity, functional impairment, and risk before initiating medication. Choose the drug based on patient-specific factors: age, sex, pregnancy status, medical comorbidities, substance use, and past or family response. One drug never fits all patients. Start with the lowest effective dose and titrate slowly. This reduces adverse effects, improves adherence, and increases long-term treatment success. Actively monitor clinical response, side effects, and relevant laboratory parameters. Prescribing without monitoring is incomplete treatment. If response is inadequate, reassess the diagnosis and optimize treatment by dose adjustment, switching, or augmentation, based on evidence and guidelines. Once stable, continue treatment for the recommended duration. When stopping, taper gradually when needed and monitor closely for relapse or withdrawal. For exams and practice, remember this line: good psychiatrists don't just start drugs. They diagnose accurately, monitor continuously, and stop safely. Thanks for watching. If you found this helpful, please subscribe, like, share, and comment for more clinically clear medical education.